Good evening, friends. Let us start the session now. Liver transplant is a very important topic for INISS as well as for Neet SS exams. But the number of questions being asked in the last few years is very less. But anyhow, I'll be discussing all the points from Bailey and Love and from the Sabistan in this discussion. So I have shared the PDF in the group, WhatsApp group, but don't use it. Just answer the question from the video. You can read it afterwards. Most common indication projected to become in future for liver transplant. So what is a common indication of liver transplant for future? Yes, you can post your doubts and queries in the chat box. Let the session be interactive so that I will also be answering your queries. Most common indication projected to become in future for liver transplant from Bailey and Love. What is the answer for this? Yes, very good. So what is the correct answer? Very good. No, not B virus. iPhone, Batma, all are correct. It is non-alcoholic. In future, answer is non-alcoholic fatty liver disease. What is the answer for today? Present day, what is the common indication of liver transplant? 10 years back, what is the common indication? Back 10 years back, it is hepatitis C virus. Now, hepatitis C virus and B virus both have gone down because of the excellent drugs available. Okay, lamivudine, many drugs, protease inhibitors are all come. So therefore, this incidence has come down. And what is the present indication of common indication of liver transplant is alcoholic liver disease. Don't forget this point. Very basic question. So alcoholic liver disease is the answer for present day. In adults, in children, what is the common indication? This is a very common MCQ. In children, the common indication is extrahepatic biliary atresia. So no doubt in that it is extrahepatic biliary atresia in children. Okay, these are simple questions. Don't forget answer C. So whatever I'm discussing is there in the theory. That is why I'm telling you not to see the PDF. You can read it afterwards because I will be explaining, and afterwards when you read, it will be easy for you. Acute liver fulminant liver failure requiring transplant is around 10% of the liver transplant activity. So we are going to discuss about acute fulminant liver failure. So NASH will be the future common indication of liver transplant. In children, biliary atresia is the most common indication of liver transplant. All these are from Bailey. And very important point, table from Bailey and Love. What is acute fulminant liver failure? Acute fulminant liver failure is a sudden failure of liver within 8 weeks. So acute liver failure is sudden liver failure within 8 weeks of onset of symptoms and no recognized chronic underlying disease. So that is called as acute liver failure. So no chronic underlying disease is available. Suddenly the patient went for liver failure. Example in adults, paracetamol, A and E, not B and C. Okay, it is A and E. Wilson's autoimmune fatty liver. In children, drugs, hepatitis A and E, and acute fulminant, acute Wilson's disease. So this chronic liver disease is very easy. You can see whatever causing cirrhosis will cause the problem. So that is not so important. And similarly, metabolic disease, what are the metabolic disease for which liver transplant is useful is also there. And most important update from Bailey and Love is we can also do transplant not only for HCC, but also for cholangiocarcinoma, liver mets from neuroendocrine and colorectal cancers. We can do liver transplant in these cases. So in children, hepatoblastoma and even benign tumors with the disabling symptoms like Kasabach-Merritt syndrome caused by huge hemangioma, multiple adenosis, all those things also we can sometimes do liver transplant. So very important. So what are the causes of liver transplant? Please don't forget this table. So now answer this question. HLA and ABO incompatible liver transplant. Mark the wrong statement. I hope you have a basic idea about the transplant because Dr. Venkateshwar covered in liver transplant, covered basics of transplant and renal transplant. So I'm sure you will be having a basic idea. Regarding HLA and ABO incompatible liver transplant, mark the wrong statement. HLA matching is not necessary in liver transplant. Liver is immunologically preserved organ. ABO incompatible transplant cannot be done for liver transplant. Increased infection is seen in ABO incompatible transplant, which is wrong statement in this. Yes, very good. ABO incompatible transplant cannot be done for liver transplant. This is wrong. So you should understand about HLA matching and ABO matching. ABO matching is very important for kidney and HLA matching is very important for liver. Both HLA matching and ABO matching are not so important for liver cases because liver is immunologically preserved organ. Don't forget this. Liver is immunologically preserved organ, so there is no issue in liver. Therefore, HLA matching is not necessary in case of liver transplant. ABO incompatible transplant has been started as a part of extended donor criteria. Extended donor criteria included ABO incompatibility also, but the only problem is there is increased rate of infection due to adding of high immunosuppressants. Why there is increased infection in ABO incompatibility? Because we will be adding high dose of immunosuppressants in these patients. So just remember this concept. Theory is here. So I'll be whatever I'm discussing as theory is there in the printout. Just you can go home and you can read. There is increased risk of infection owing to higher immunosuppression protocol and a higher incidence of antibody-mediated rejection with this type of ABO incompatible liver transplant. Okay, please remember, this is very important. False statement regarding liver transplant for malignancy. So all of you know the very basic criteria known as Milan criteria for liver transplant in a cirrhotic liver. As per this criteria, single lesion less than 5 centimeter or 3 lesions all less than 3 centimeter, we can do transplant. This is Milan's criteria. This is extended into UCSF criteria. Single lesion less than 6.5 centimeter or 3 lesions all less than 4.5 centimeter or all the lesion together it is 8 centimeter. If there are 3 lesions, 4 plus 1 plus 2, 8 centimeter. So all lesions together should be added as 8 centimeter. This is UCF. So from 5 centimeter, it increased to 6.5. From 3 centimeter, it increased to 4.5 centimeters in UCF criteria. And one more criteria came known as UKHCC criteria. According to UKHCC criteria, single tumor, which is 5 to 7 centimeter, which is not progressed in the past 6 months, or there are 5 lesions, all 5 lesions, there are 5 lesions, all less than 5 centimeter. So 1 lesion less than 5 centimeter or 5 lesions all less than 3 centimeter. So 5 lesions all less than 3 centimeter. Okay, this is UKHCC criteria. UKHCC criteria, single lesion 5 to 7 centimeter and not progressed for 6 months. For 6 months is included. So the answer here is false statement related to liver transplant for malignancy. UCF 6.7, UKHCC 5 to 7. Colorectal cancers and cholangiocarcinoma transplant not indicated is wrong. It can be done. Neuroendocrine tumor mets transplant can be done. Okay, so this is correct answer is C. C is a false statement. So don't forget these 3 criteria. Definitely they'll be asking. These are new updates. Milan, UCSF, UKHCC. So all the lesions together should be 8 centimeter. So total size should be 8 centimeter as per UCSF criteria. So tumors and transplant related points, you should never forget. Tumor recurrence after liver transplant for HCC will be from 8% to 20%. 8% if I use Milan criteria, 20% maybe for UCSF and other criteria which are used, there may be recurrence. Primary malignant tumors constitute less over 1% of all childhood cancers, and the most common tumor that require liver transplant in children are hepatoblastoma. So don't forget cholangiocarcinoma, colorectal secondaries, neuroendocrine secondaries are now transplanted. They are now transplanted. So which among the following technique is called as piggyback technique in this picture? Which among the following technique is piggyback technique? So I'm sure this is a very basic question, Neet PG level question. You should never have a doubt in this. So piggyback is B. Very good. Most of you are correct. You are correct. It is piggyback is B. Now, let us discuss few points about the transplant related procedures. Okay, related to the transplant related procedures. So now I want to discuss orthotopic liver transplant. Orthotopic liver transplant. Don't forget this. Orthotopic means we are going to keep a new liver in the same place where the liver should be. So the donor liver is going to be kept in the recipient normal location. This is IVC. And this is IVC. I'm drawing little non-anatomically, so don't worry about it. So this is IVC, and this is the liver attached with the cirrhotic liver attached with the IVC. So assume this is cirrhotic liver attached with the IVC. So now this is a recipient. Okay, this patient is a recipient. So most toughest operation is recipient hepatectomy. You should understand, in a liver transplant, most toughest operation is recipient hepatectomy is the first important step. And the donor hepatectomy is going on one side. The most toughest step is going to be a recipient hepatectomy, in which we remove the IVC along with the liver like this. So it is most easiest. So easiest is to remove the IVC along with the deceased liver. Remove it along with the deceased liver. Now I have removed the recipient deceased liver with IVC. And now I need to bring a new organ, that is I'm going to bring the classical organ from the donor. I'm going to bring a new organ now. This is the organ from a donor, good organ from the donor with its IVC. This is usually taken along with IVC, and this will have a portal vein. This is portal vein, and this will have a hepatic artery, and this will have the bile duct. So everything will be present in this bile duct. Everything will be present in this donor. This is a donor organ. So now I am going to bring this and keep it here. So classical surgery, we will keep it as such in this place, in which first I will do, first anastomosis is suprahepatic IVC. Please don't forget. First anastomosis is suprahepatic IVC. Second anastomosis is infrahepatic IVC. Third anastomosis is portal vein. Fourth anastomosis is hepatic artery. Fifth anastomosis is bile duct. This is order. Suprahepatic IVC, infrahepatic IVC, portal vein, hepatic artery, bile duct. And most important thing is, usually we would have infused cold preservative solution into the donor liver. So before completing the IVC anastomosis, I should infuse the blood to flow through the portal vein, and I should only suture. The complete anastomosis will be done only for suprahepatic IVC. Infrahepatically, I will have a gap, so that the fluid I'm going to flush inside the liver through the portal vein, the blood is going to flow. No, that should be taken out through this way, because it is not a good blood. The blood or the solution which is already present inside the liver, University of Wisconsin solution, is full of toxic substances that will cause reperfusion syndrome. So therefore, I will tell you a small correction in the order. Suprahepatic IVC first. Second, infrahepatic IVC is incompletely closed, not fully closed. Then third, I will do the portal vein reconstruction and allow the blood to flow. I will not allow the blood to enter the systemic circulation. It should come out of the IVC gap, infrahepatic IVC gap. It should be taken out. Then I will complete infrahepatic IVC, and then I will finish the fourth anastomosis of hepatic artery, fifth anastomosis of bile duct. So this is the order of anastomosis in a classical reconstruction procedure. So please don't forget, this is how I will do the classical reconstruction procedure for a orthotopic liver transplant. But the problem is, when I'm cutting the IVC, the patients will temporarily need a veno-venous bypass. From the IVC, inferior vena IVC, I should go and connect it to the IJV. That will be a bypass done externally. So that is needed for these patients. And simultaneously, I can also connect the patient's portal vein with this bypass for temporarily. So therefore, portal venous bypass and IVC bypass will be done. When I do a portal venous bypass, it decreases the edema of the bowel. It decreases edema of the bowel. So it is having so much of benefit. Therefore, it is having so much of benefit in an orthotopic liver transplant. So this is orthotopic liver transplant. The only problem is there is so much of hemodynamic instability because IVC is clamped and there is a bypass done. To prevent this hemodynamic instability, there came a procedure called as piggyback operation. That is what we are discussing here, in which I am not removing the native IVC. I have not touched the native IVC. This is very difficult, more difficult deceased hepatectomy, because from the deceased liver, there will be so many collaterals to the IVC. Disconnecting all these collaterals is going to be a real challenge. Donor hepatectomy will be very difficult. After that is done, now you can bring you can bring it and keep it there. You can bring it and you can keep it with its IVC. So I can bring it and I will anastomose it here. That picture is called as IVC to this hepatic vein origin. No, that place I will anastomose this IVC. And this is the liver. This is end to end. This is suprahepatic IVC, which is anastomosed in an end-to-end operation. So this is piggyback. The major advantage is there is no hemodynamic instability in this patient. Therefore, the flow is very well maintained in IVC, no hemodynamic instability, and this is a good surgery. But the problem is recipient hepatectomy is very, very difficult. So this can be done either as an end-to-end, or I can also do as a side-to-side. So side-to-side also is option available, but it is not called as piggyback. Side-to-side IVC. Like this also can be done. IVC to IVC, side-to-side also can be done in this procedure. So please remember, this is a very important topic. Don't forget this. This is piggyback operation. This is side-to-side, side-to-side. This is a classical. Okay, whatever I discussed is there in the theory. Portal limb of the bypass also reduces the portal hypertension and congestion of the bowel during the implantation phase and potentially reduces the blood loss. So by doing a bypass classical technique, it is having one advantage. By reducing the portal pressure, we are going to have less blood loss. So don't forget, piggyback is end to end. Side to side is another technique shown in the image. Okay. So order of anastomosis, never forget for your exam: IVC, portal vein, hepatic artery, bile duct. Bile duct anastomosis is the Achilles heel of this operation. From Bailey and Love, the Achilles heel is bile duct anastomosis. Okay, so we have to leave the IVC opening not completely closed, because I need to wash the cold solution outside by flushing. So what is the method of doing bile duct anastomosis? That's another important question every time asked in exam. So when I'm doing a liver anastomosis, I told you we will be anastomosing the bile duct of the donor liver. This is a donor liver. Remember, this is a donor liver. I will anastomose this donor liver with the recipient's bile duct. This is usually done. So by means of bile duct to bile duct anastomosis, maybe we will be keeping a T-tube along with that. So we will be keeping a T-tube temporarily, and we will do a bile duct to bile duct anastomosis always. So this bile duct to bile duct anastomosis is not done in following cases. What are the patients? Are not advised in, number one, primary sclerosing cholangitis, and not done in extrahepatic biliary atresia, because these cases are problems with the bile duct itself. So we cannot use bile duct in these cases. So in these cases, I should do a Roux-en-Y hepaticojejunostomy. So when will you do Roux-en-Y hepatectomy and you won't do a bile duct to bile duct anastomosis? Is a Neet SS 2020 MCQ. It is asked in exam 3-4 years back. So please don't forget, it is a Neet SS exam question. Bile duct to bile duct anastomosis is contraindicated in following. It is not done in PSC and extrahepatic biliary atresia. Don't forget this common MCQ for your exam. This is a very important concept for those who are writing INISS exams. In INISS exam, when you go to the exam hall or in the interview, there will be always a question. During liver transplant, what is most important monitoring needed is viscoelastic monitoring, because the coagulation factors are now going to get altered because of the blood transfusions and liver derangement, etc. Therefore, we have two methods of measuring the prothrombin time, INR, fibrin, fibrinogen, everything. For that, we have two machines. This is thromboelastography and this is ROTAM. So ROTAM is a dynamic measurement. It will show you immediately the values, etc. can be shown immediately in the machine. But this is like a graph. It is an indirect measurement. It will take little time. This is thromboelastography. And this thromboelastography will give you an image graph. Can you see the image graph? This is the graph shown in the thromboelastography. So this is having a coagulation phase and fibrinolysis phase. The coagulation phase and fibrinolysis phase. And this is a normal graph. What you are seeing here is like a fish is a normal graph. It looks like a fish. No, this is a normal graph. There are problems in coagulation, problems in fibrinolysis, everything can be detected. And usually in Viva, they will be asking, what is this alpha angle? So alpha angle measures the speed at which fibrin buildup and cross-linking takes place, and hence assess the rate of clot formation. Alpha is the rate of clot formation. It depends on fibrinogen. Normal degree is 47 to 74 degree. So this is normal thromboelastogram. This question is a Viva question from INISG people. So preparing for SG, this question will be asked. So what is this angle? Alpha angle is the rate of clot formation, depends on fibrinogen level. So based on this level, whether there is a decrease in fibrinogen or increase in fibrinogen, we will transfuse platelets or fibrin or FFP, everything will be transfused according to these values. So this is very important basics, not from Bailey and Sabiston. So what are the types of liver transplant? We are going to discuss all these type of transplants. We are going to discuss one by one now. Let us discuss all these transplants one by one now. So I'm going, this main topic, this section is going to discuss the various types of transplant. Live donor transplant in children is first done by Silvano Raya. Okay. And Russell Strong did the successful transplant. So Silvano Raya, it's a failed transplant, but successful done by Russell Strong, and adults it is done by Tanaka. This question was asked last year again. So live donor transplant in adults is done by Tanaka. And who did the split liver transplant? Anybody? Though these questions are not from Sabiston. Split liver transplant done by Pichel Mayer. Split liver transplant done by Pichel Mayer. Pediatric live donor transplant done by Russell Strong. Tanaka did the live donor transplant. Who did the first liver transplant? Basic question. Basic question. What is it? Who did the first liver transplant? Yes? Anybody? Yes? Stalls. Stalls. Very good. Very good. Very good, Mohammed. Very good. So Stalls did the first liver transplant. So that and all is very basic question. Split liver transplant, you remember as Pichel Mayer. Pichel means splitting. Pichel means, if we used to tell Pichi means liver, in Tamil it is splitting. So Pichel Mayer divided the liver. Tanaka did the live donor transplant in adults. A strong person, Russell Strong, did it for successful pediatric liver transplant. Okay. Yes. False regarding living donor liver transplant. So false regarding living donor liver transplant. Right lobe grafts are commonly used. Ideal graft recipient weight ratio must be 0.8%. Graft volume by standard liver volume should be more than 35%. Remnant liver mass in a donor must be 30%. 90% of the liver transplant in Western are live donor transplant, which is wrong in this. Yes? D is wrong. So let us discuss. So the answer is very simple question. D is wrong question. Answer here. So please understand. Live donor transplant. Live donor transplant versus deceased brain donor transplant or cadaveric transplants. We call it simple as cadaveric transplant. Deceased brain transplant is not done in some Eastern countries like Korea, or decreased in China and India. Okay, in China, not India, in China. In China, it is very less because they believe it is superstitiously keeping a dead person's organ in their body. They feel it is superstitious and they will feel like some external soul sitting in their body. So this type of transplant is not done. So this dead cadaveric donors, 90% done in UK. 90% of transplants in UK and US are dead donors. Live donor transplant is 90% in East Asian countries like Korea and Japan and China and all. Live donor transplant is more common. Don't forget this basic point. If a live liver donor is going to be given, live donor is going to give the organs, the segments he will be giving will be usually 5, 6, 7, 8. In an adult situation, they will give organs 5, 6, 7, 8 in adult donor. If it is a pediatric, usually they give 2, 3 alone. That is enough for pediatric transplants. So whatever it is, a donor organ after donation, donor should have how much FLR? FLR in a donor, a good donor should be more than 30% to prevent liver failure and death in the donor. Please don't forget this. They should not die because of giving an organ. And if I am talking about recipient, this is a recipient. If I am going to keep a new liver for this recipient, whether it is from a live donor, I'm going to keep part of the liver for this recipient. This should have a graft recipient weight ratio of more than 0.8. If it is less than 0.5, there will be small for liver syndrome develops. Small for liver syndrome develops. The patients will go for liver failure. If GRW are less than 0.5, liver failure happens. Please don't forget this. It should be more than 0.8. So this is recorded. So please don't worry. This is recorded. You can always see the recorded version later. Those who joined late, you can always see later. Voice is going fine. I'm seeing on another device. If your net is not good, you can see the letter. Okay. In YouTube, it is recorded. It will be shared in the YouTube. So small for liver syndrome will go for liver failure. So therefore, GRWR should be more than 0.8. It should be more than 0.8. It should be more than 0.8. Or in otherwise, graft volume divided by standard liver volume should be more than, that is more than 35%. So the graft volume, in otherwise, graft volume should be 35% of the normal liver he should have had. That is very important. So these are some of the basic concepts from Bailey and Law. So when I'm going to talk about donor should have at least 30% of the liver. Donor should have at least 30% of the remaining liver. Recipient should receive GRWR at a ratio of more than 0.8, and graft volume versus standard liver volume should be more than 35%. So don't forget these MCQ points from Bailey and Law. So the answer here is right lobe grafts are commonly used in adults. Yes, 5, 6, 7, 8 segments are used. Ideal GRWR must be 0.8 and graft volume by standard liver volume should be more than 35. Remnant liver volume in a donor must be more than 30%. Okay, this is very important. Don't forget this. So the required graft volume is measured by either graft weight to recipient weight ratio. See, graft weight divided by recipient weight ratio. You can measure the graft weight. For example, the graft weight is 1 kg. Recipient weight is 50 kg. What will be the graft recipient weight GRWR? It will become, so by this we have to calculate. It should be more than 0.8 for a good graft. So for a good graft, it should be more than 0.8, ideally 0.8 to 1. So recipient weight, graft weight, don't forget this ratio. Graft weight divided by recipient weight. So usually the graft weight will be 600 grams, 800 grams like that. No, so you have to calculate accordingly. So graft weight divided by recipient weight is equal to 0.8 to 1.0 is a normal value. It should be more than 0.8%. Graft weight divided by weight of the recipient. That is what called as GRWR. Graft weight recipient weight ratio. Graft recipient weight ratio is called as GRWR. That is very simple. Don't get confused. So graft recipient versus weight of the recipient. So in a graft volume divided by standard liver, for example, if I should have a standard liver volume of 1500 grams, my graft volume should be at least more than 35% of this. It is more or less equal to FLR. FLR so to prevent, all these are discussed because to prevent liver failure. So this all can be calculated by a volumetry, CT volumetry, and a new software is maintained in Bailey and Law known as MEV software. To calculate this GRWR, graft volume by standard liver volume, we have an excellent software called as MEV software. This software will calculate the ideal ratios. So MEV software, this liver transplant chapter, I'm telling you, at least you should see this video 2 to 3 times, then only you'll understand. That much it will be more theoretical, because in all other chapters, whatever you read are more practical. So whatever you have seen in your practice, at least you would have seen some cases of colon cancer or even neurosurgery or cardiac surgery, something you would have seen. But liver transplant is totally, you are going to read it by imaginary. Only very few of you would have read and seen the liver transplants. So unless you have seen a liver transplant, more and more you are going to read in imaginary method. And what is there in Bailey is more than enough for a liver transplant. Extraordinary discussion is there in Bailey and Law. In fact, this latest edition, Bailey has taken all the points from Bloomgard. It is a concise content of Bloomgard. So what if you are thorough with what is there in Bailey, that is enough even to appear for ionized transplant topic. So very important topic. This is a new software used to calculate GRWR should be more than 0.8. Graft should be enough size. Okay, don't forget this. Live donor liver transplant versus dead donor transplant. 90% of the transplant in East come from live donor, whereas West come from dead donor. So dead donor. So Western countries, mostly it is cadaveric transplant. Okay. So dual graft liver transplant. You should understand now, if you have understood the GRWR, we are going to discuss some interesting points. Dual graft liver transplant. What is this dual graft liver transplant? This picture will make you understand. So this picture is explaining you, this recipient is a bulk recipient, big fellow, overweight. Remember like that. He is a overweight, bulk or big person. He is going to get liver. So we are going to bring organ from one donor, for example, A. So let us assume this is A who is going to give organ for this by giving this organ, this fellow is not able to reach GRWR more than 0.8. So because this fellow is a very small fellow, by giving his organ to this person, the organ is not sufficient. Either the organ is not sufficient for the recipient, or after giving his FLR is less than 30%. So what will I do? Is FLR less than 30% or GRWR is less than 0.8? So in such cases, I am going to take organ from two people, two liver donors. Two live donors are coming in fact, A and B. Now, for one person, this big bulk fellow, two people are going to give two small segments of liver so that his GRWR will be more than 0.8. That is called as dual graft transplant. So understand the terms. Dual graft transplant is a transplant in which the recipient is big, so his GRWR is not adequate, so he is going to receive two segments, two liver from two different people. Very complicated surgery. To do this dual graft transplant surgery, I need 3 OT theater. 2 donor hepatectomy will be done and 1 recipient hepatectomy will be done. It is a more complicated procedure, and such type of live donors are not done in India. It is only done in Korea. So in this, we are going to give left lobe 4A, 4B, 2, 3, 4A, 4B, 2, 3 of 2 people, or else 5, 6, 7, 8 of one person, and 4A, 4B, 2, 3 of another person. So like that, it can be given in a different way, but it is a technically demanding operation. Technically very demanding and requires massive infrastructure where 2 donor hepatectomies and 1 recipient surgery has to take place at the simultaneous same time. It is a complicated surgery, not commonly done, but just know the name. Dual graft liver transplant. So the question is, you have to understand where is dual graft liver transplant done. In the case, recipient is big. So you remember one answer, recipient is big. Recipient is a big fellow, bulk fellow. So he needs big liver. Such cases, the live donor is unable to give his half of the liver. Such cases, we have to go for 2 donors for 1 recipient. So another question, liver splitting. So you have to understand another interesting concept of split liver transplant. So split liver transplant concept, very interesting concept. So split all this is a donor operation. Okay, I am going to discuss about the donor, cadaveric donor. Okay, live person is not going to give 2 split liver. It is a cadaveric organ operation. So now the patient is brain dead. I am going to retrieve the liver. I am going to retrieve this liver. So this liver, when I am going to retrieve, I am going to use 2 separate places. 5, 6, 7, 8 can be given to an adult, or even 4, 5, 6, 7 to an adult, or 2 and 3 to a child. So whatever it is, or I can give 5, 6, 7, 8, 2, 3, 4 to another adult, small adult, 5, 6, 7, 8 to a bigger adult. But whatever it is, I am going to, after taking the liver, I'm not going to give 1 full liver to one person because of the demand in the community for waiting list. So therefore, I'm going to split the liver. So splitting of the liver can be done in situ while operation is going on itself, and the surgery is, when I'm retrieving itself, I will do a in situ splitting. But it is not commonly done because of time sequences. We take out 1 liver fully, and this is cut in the backbench by backbench fellows, backbenchers. This is called as ex situ, which is good for the patient, for the recipient. Can you tell me which is good for the recipient? In situ is good for the recipient, or ex situ is good for the recipient? In situ is good for recipient because when I'm cutting the liver itself, I will arrest all the bleeding vessels. I will arrest the bleeding vessels. I will arrest the bile duct. So in situ is associated with decreased bleeding, not during the hepatectomy, during bleeding on transplant over the recipient, because already I have arrested all the vessels. I have closed all the biliary small vessels. So when I'm going to keep this splitted liver, which is already fine-tuned during the surgery itself, they will not have any bleeding on the recipient. Please understand this concept. When I'm going to keep this one person, this another person, both of them will not have bleeding. So decreased episode of bleeding and decreased cold ischemic time. Because after splitting, I'm going to directly take the, so inside the liver, there is blood flow is still going on. It's a brain dead. So I'm going to take this organ. Cold ischemic time is now completely reduced because two organs have to go to two different places. So therefore, there will be no time delay. Therefore, cold ischemic time is decreased, bleeding is decreased. So in situ, what is the advantage? Decreased cold ischemic time, decreased bleeding on transplant to the recipient. So don't forget this point. This is a very important, simple question. So you can see the answer now. Liver splitting procedure done in situ have the following advantage over the ex vivo splitting, except, can you tell me? Hemostasis can be achieved better in situ. Prompt transportation is possible. Less blood loss during reperfusion. Re-exploration rate is common in situ split, which is wrong. Which is wrong in this. See, many times in a ex situ, yes, ex situ procedure, they will bleed in the post-operative period and we need bleed or there may be bile leak and I need to go for a re-exploration. So re-exploration is more common in ex situ. I hope you're understanding the concepts, simple concepts, don't get confused. One by one, the basic concepts, all the concepts I have made my own images which are not there in Bailey. Okay, this is a ex situ splitting. The liver is taken and splitted outside, okay, outside. So split liver transplant is a valuable option. I have discussed this in situ, ex situ. If you see this picture, you'll understand. This is a picture made by me. Split liver transplant is done only for, so I have numbered 1, 2 like that. We are going to discuss 7 concepts. So split liver concept. Ex situ, you have to used by backbenchers. So there is increased re-exploration risk in these patients. These are images made by me, not from books. So please understand this. In situ, there is all vessels ligated. So there is decreased blood loss and decreased cold ischemic time. So when you read this theory, you will be many times confused in Bailey and Law. You may not understand many lines. So better you should make some illustrations and make it easier for yourself to understand. That is why I made these illustrative images. So first image I have made is very clear image. Dual graft transplant. Don't forget, dual graft transplant for a bulk recipient. Second image I have made now is a ex split or in situ split. Okay. Reduced liver transplant. What is this new concept of reduced liver transplant? Now I have one liver. This liver is going to be going for this small fellow. This is a thin fellow. This liver I cannot go and keep inside him because he is very small. This GRWR will become more than 1.2. You should not keep a big liver also. Please remember, you should not keep a big liver also. We should keep a ideal liver 0.8 to 1. So GRWR is very big. So what will I do? In such case, I will cut and dispose this liver. It is more or less like split technique only, but this segment is not used for anybody else. It is disposed. This is known as reduced liver transplant. For a small adult, dispose the extra liver in a donation after brain death. This is also done for brain dead donors. So use only reduced liver. This is called as reduced liver transplant. So dual graft, split liver, reduced liver. 3 concepts I hope you have understood. The 4th concept now we are going. Regarding extended criteria donors, the following are included except extended criteria. So from the basic criteria, we have extended the criteria for the donors. So regarding extended criteria donors, the following are included except. So from the donors, advanced stage also we are taking more than 60 years also now we are taking the organ. Macrovascular steatosis also we are taking the organ. ICU patients who are admitted before this organ retrieval for 7 days also we are taking. B antibody, HBV, HCV, HIV, all donors are accepted now. Even active drug abuser is accepted now. There is no answer in this. All are correct. Answer is all are included. Okay, answer is all are included. Donation after cardiac. See, before going to this, see this table. From Bailey and Lowe, this is a high expected table. What are all the extended donor criteria? Advanced age, fatty liver. So please remember, advanced age, fatty liver, DCD donors. I hope you know what is DCD donors. Donation after cardiac arrest. Cardiac arrest, patient has already died. There is a classification you will be discussed in the general part of this thing, that is Maastricht classification. Such donors are coming as extended criteria donors. Interesting line is this: DCD donors are not done in India. It is a crime in India. Please remember, taking organ from a DCD donor is a crime in India. We don't do that. It is done only in UK. So organ dysfunction, ICU, hypernatremia, bilirubinemia, elevated enzymes, vasopressor are being used, B antibody, B antigen, C virus, HIV, drug abusers, even extrahepatic malignancy, hold ischemic time more than 12 hours. These are all given as extended donor criteria. Please don't forget, in extended donor criteria, DCD is used, donation after cardiac death. There are some disadvantages in this. That is very important for many MCQs. DCD donors are not done in India, so no discussion at all in India. But when it is done in Western countries, DCD means there is no blood flow to the biliary system. So therefore, bile ducts are very important. They receive blood supply from hepatic artery, will get damaged. So therefore, there is a complication known as cholangiopathy. Bile ducts will get no blood flow, and in future, after doing the anastomosis also, the bile duct could have gone for cholangiopathy in such patients. So cholangiopathy is very common in DCD donors. Okay, not from deceased brain donors, not from live donors, more common from DCD donors. This is an MCQ. Worldwide, there is a considerable variation in the contributions that DCD makes to deceased donation overall, while some countries have no DCD programs, such as India, where it is illegal. Okay, DCD donors reduce waiting list mortality. That is a point, that justification given by UK people is, instead of waiting for a good liver, waiting for that good liver, many of the patients who are in waiting list are dying. Instead of making them die, at least we will do a bad liver for them, bad liver transplant for them to make them survive until the better liver comes. Like that they are saying. So therefore, it is done. This is not done in India. Deceased cardiac donors are, DCD donors are heartbeat stopped. Heartbeat stopped donors have more increased warm ischemia time. So warm ischemia time is very high in these patients. So warm ischemia time should be ideally 30 minutes only. Ideally, it should be 30 minutes. In these cases of donation after cardiac death, the warm ischemia time is increased. So tell me, which category in Maastricht classification is a good DCD donor? Yes, it's a question from general transplant. So if you read general transplant only, many concepts you will understand in liver. Which Maastricht classification has better category? Category 1, 2, 3, 4. No. Which category is good in DCD donors in Maastricht? Yes, very good, Sneha. That is correct. Best is 3. In Maastricht, category 3 followed by category 4. All others are poor categories. Category 3 is the best because he is still having he is a brain dead patient who is in ICU, who will die when I stop the cardiac supports. That is category 3. Please go through that from basic chapters. 3, not 2, only 3, second 4. Actually, 3 is the best. So now the next concept is on auxiliary liver transplant. I want you to never forget this auxiliary liver transplant concept. Don't forget this. What is mean by auxiliary? A patient who is having an acute fulminant liver failure. Acute liver failure. His liver, this is a fulminant liver failure liver, which has stopped its function now temporarily. It will not totally fail. It is temporarily stopped functioning. Therefore, what I will do, I will bring an organ. I will bring an organ according to King's College criteria. We will be transplanting the organ. So what they used to say is, an auxiliary liver transplant, that liver which got acute failure, no, it will usually recover. It will become normal after a few months. Therefore, until that, olden days, they used to keep a liver just beneath that liver. This is called as heterotopic auxiliary liver transplant. So then later, they removed the native liver and they kept it in the same place also. This is called as orthotopic auxiliary liver transplant. There is a problem with the heterotopic liver because heterotopic liver transplant patients had so many venous drainage issues. Venous drainage is not good in heterotopic liver transplant. So they dropped this program of heterotopic liver transplant. At the same time, they felt very much unhappy to remove a good liver, which will recover after few years. Therefore, there came a modification. That is what now done, known as auxiliary partial orthotopic liver transplant. APOLT, don't forget APOLT transplant. auxiliary partial orthotopic liver transplant. I removed half of the diseased liver. See, half of the diseased liver I removed. At the same time, I kept a new liver in the same place. This is donor orthotopic. So I have now removed half of the diseased liver, and at the same place I kept a good liver. So now after a few months, this original, his own liver will regenerate and will become bulky and start functioning. At that time, stop the immunosuppressants. That is the important concept of this. I will stop the immunosuppressants once his old liver starts functioning. So once his old liver starts functioning, we will stop the immunosuppressant. This is called as auxiliary partial orthotopic liver transplant is what commonly done now. So most commonly done operation now is auxiliary partial orthotopic liver transplant. Heterotopic and fully orthotopic are no more done. Answer this question now. Regarding auxiliary liver transplant, false statement is heterotopic auxiliary liver transplant is commonly done. No, wrong. In orthotopic auxiliary liver transplant, donor hepatectomy is a major issue. Yes, unwantedly we are going to remove the donor liver. Unwantedly we are removing a donor liver which will survive after some time. Is a major issue. Yes. Recent update is auxiliary partial orthotopic liver transplant. Immunosuppression is withdrawn after native liver regenerates. So after the native liver regenerates, we will withdraw. So the wrong answer is heterotopic is wrong. So please understand this concept is explained here in this picture. So first picture is heterotopic, kept below the diseased liver. Second picture is remove the diseased liver and keep a new liver, orthotopic. Third picture is auxiliary partial orthotopic liver transplant. Stop immunosuppression once the diseased liver recovers. Tell me one indication of this done in children. This procedure, auxiliary liver transplant, is done for fulminant liver failure. But in children, it is done for one indication. In children, this procedure is now done for metabolic disorders like amyloidosis and all. Also, we can do this. Metabolic disorders, maple syrup disease and all, we can do this. So there is a line from Bailey because they are saying in next few years, there may be some treatment found for these metabolic disorders. Therefore, for gene therapy, we need their native liver. That is what mentioned in Bailey. You can see this line from Bailey and Love. Very interesting line from Bailey is here. In metabolic liver disease in children, auxiliary partial orthotopic liver transplant is performed with the intention of keeping the part of native liver for future gene therapy and study. That is very interesting line. This can come for you as an MCQ. So otherwise, whatever I have explained is there. Whatever I explained is there in the theory. So please read the theory slowly again and again with the images I have made, and again listen this video at least 2 to 3 times. This is a picture showing you diseased liver. This is diseased liver. This is donor liver. You can see both are kept side by, like looking like a full liver. Orthotopic liver transplant partial. So now another interesting concept is coming. Domino liver transplant. Domino. So most of you know this answer. This is a PG entrance question. Domino liver transplant is done for patients like familial amyloidosis, maple syrup urine disease. These are disorders with a protein chain dysfunction inside the liver. So this patient's liver is a good liver. It is characteristically good liver. It is doing functional enzymes, etc., etc. But some proteins which are needed in the liver is not produced in amyloidosis and maple syrup disease. So what we will do, this fellow will donate this liver to a patient who is going to die of end-stage liver disease. He is a case of end-stage liver disease or an HCC patient. We will give this liver to him. This liver will be given to him. And this patient, amyloidosis patient, is going to receive the liver actually which has to go to this patient. This liver is from the waiting list pool. This will be diverted to him. So now this is one liver saving 2 patients. This is known as domino. So this liver is now domino transplant. Will this recipient develop amyloidosis or maple syrup? They may not develop usually. Even if they develop, it will take 20 more years, 10 to 20 more years. So therefore, domino transplant is well done for amyloidosis and maple syrup disease. So the liver is brought here. That waiting list pool, the liver is coming to this amyloidosis patient, and this amyloidosis liver is going to the first waiting list patient who was waiting for the liver. That is why amyloidosis is an exception to MELD criteria. So it's an exception to MELD. We cannot wait for the MELD to satisfy this score. An exception to MELD. Don't forget this concept of dominoes. So I have explained this dominoes liver transplant. Please go through the dominoes liver transplant. Amyloidosis liver, end stage liver disease, it is going. Whereas waiting list pool liver is coming to this guy. Okay. So this is an example of dominoes, is an example of MELD exception. So dominoes liver transplant is a case in which familial amyloidotic polyneuropathy, the patient is who is outside the transplant criteria of a liver malignancy will be given to a patient of HCC. Even if they develop amyloidosis, it will take 20 years. Okay, therefore, it is nothing to worry. Even if they have no recurrence of tumor and become symptomatic from FAP in the future, they can be afforded a retransplant again. So once there is no recurrence of tumor and there is a amyloid, you can always wonder, sir, what will happen? This fellow, will he not develop amyloidosis? Yes, if he develop amyloidosis, it takes 20 years, and 20 years that I will do another transplant. That is what they are saying. Okay, they can do another transplant. The next concept is on paired exchange liver program. Paired liver exchange program, very interesting concept. You can understand from this picture. Just this one picture will make you understand. So I am blood group A. I am going to donate my blood. This is myself. Hope this is myself. And I am going to donate my liver to one of my close relative. And he is B group. One of my relative is B group. I am going to donate A group. I am going to donate for a B group. Same way, you are B group. You are going to donate your liver to one of your recipient A group. Now, there is ABO incompatibility matching. So very commonly done in kidney transplant. This concept is used very commonly in paired exchange program, is commonly done in kidney transplant, most commonly done. So what we will do now, we will discuss, and I will give my liver to this A blood group recipient, and you will give to my relative. So mutually we will exchange. This is very commonly done for kidney transplant and liver transplant. There are many logistic issues. Logistic issues in the sense, I am going to give liver to your relative, and by chance, if something happens to my relative from your organ, I will feel very bad. Or something happens to me by giving an organ to an unknown person, I may feel very guilty. Or it is totally waste of, like that I used to feel. Therefore, it is logistical issues is one of the reasons. So this is done for ABO incompatibility. Similarly, size incompatibility. This donor is a 140 kg fellow, and this recipient is a 50 kg. And this recipient is 100 kg, and this donor is 50 kg. So now I can exchange same way. So not only for ABO, paired liver exchange program is done for anatomical issues, size incompatibility, ABO incompatibility. The major point is, as I told you, it is very much depressing if something happens. Therefore, compared with the kidney paired exchange, liver paired exchange is inherently more complex, more morbidity, more mortality to the donor and to the logistics involved. Hence, it is not widely practiced. Like kidney, it is not widely practiced. So liver program, answer this question, allows liver donors and their intended incompatible recipients exchange liver with another donor recipient, which is more compatible. True. ABO incompatible, size incompatible are important reasons, more commonly performed than kidney is wrong. So kidney is commonly done because kidney transplant is not going to have any procedure related complications. Usually it is very less. Therefore, for kidney transplant, it is commonly done. Liver program exchange reduces the effective waiting list for liver donors. It is going to reduce the effective waiting list of the liver donors by changing the donors from. This waiting list for liver donors is not from, you should understand, this is not from a dead pool. This is done in a live donor only. In live donor also, there will be waiting list. So because that organ is not suitable, so we'll be waiting. No. So that will be reduced by this program. So liver program, paired liver program exchange is a good program, but it is not commonly practiced due to the logistics involved in this. So what are the places it is done? ABO incompatibility, size incompatibility, anatomical issues are the places where it is being done. So this is a very important table. The discussion is going more and more in liver transplant only because of the shortage of the liver. It is all because of the shortage of the liver. If there are so many people ready to come forward and donate their livers, we will not be discussing anything. We will not discuss split liver. We will not discuss anything. We'll only discuss liver transplant. So therefore, to increase the donor pool, we are now implementing an organ donation opt-out system. What is this? Organ donation opt-out. So in India, we have an opt-in. I would like to donate my eyes, kidney, liver, body if I die in an accident. That is an opt-in. But in UK, you doesn't tell anything. Your organ will be taken automatically. If you don't want your organ to be taken, you just sign out opt-out system like this. So it is an opt-out in UK, and in UK, it is opt-out. In India, we have opt-in. So we should actually have an opt-out system from a brain dead donor, since we don't have an opt-out system here. So therefore, in UK, there is opt-out system. All of you are donor. Once you get a brain dead, you all donor in UK. Use of marginal disease brain donors, cardiac donors, split liver, increasing live donor, HCV positive, and improving the quality of donor by machine perfusion systems. You will understand this later. So reduce immunosuppression. All these are used in strategies to overcome the shortage of liver for transplant. Okay. So immediate post-transplant care, very important value that we'll be watching is lactic acid and falling INR. So lactic acidosis should be metabolic acidosis corrected. INR normal means you have done a good job. Your patient is recovering very well. And always we have to do Doppler ultrasound to know that there is a hepatic artery free flow. So patient will be in ICU for 24 hours to 2 days. And after 2 days, we will transfer the patient to high dependency unit. Factors determining the graft function after liver transplant are, so donors, poor factors, donor age, fatty liver, DCD donors, small for size, I told you small size in live donor, increased warm ischemic time, increased cold ischemic time, type of solution, high MELD score. There is another score also used, like MELD is not mentioned, UK score, UK end liver disease. But we just remember MELD alone. Portal hypertension, technical factors, massive transfusion, immunological, all these are various factors determine the graft function after liver transplant. And most important point you should remember here is, liver is an immunologically strong organ with a large amount of extramedullary hematopoietic stem cells, and therefore produce numerous immunoregulatory substances. Therefore, liver will not go for acute and chronic rejection. Among the various organs, which organ has lower rates of rejection is liver. Lower rates of hyperacute, acute, and chronic rejection is seen because of the immunoregulatory function of liver. Therefore, no need of ABO, no need of HLA matching in liver. Okay. Regarding immunosuppressants used in the liver. So anyhow, but we will be using immunosuppressants. False statement is, induction agents like anti-thymocyte globulin is now rarely used. Once upon a time, they were using anti-thymocyte globulin. It is now stopped, and we are now using calcineurin inhibitors mostly. In a liver transplant, the most important drug post-transplant is calcineurin inhibitors. But calcineurin inhibitors, all of you know very well, it causes nephrotoxicity. When nephrotoxicity is seen, we have to go for a drug, sirolimus is used. So no long-term survival is seen without immunosuppression is wrong. There is even without immunosuppression, 20% of them, because liver is immunogenic organ, have normal survival. 20% of them have normal survival without immunosuppression. Please remember this. So immunosuppressive agents, you have to read from general topics of the transplant. Please read from them, from the urology faculty's videos. So anti-thymocyte globulin, okay, induction agents such as anti-thymocyte globulin are CD25 antibodies like basiliximab, CD52 antibodies like altuzumab, alemtuzumab. All these are not commonly used now because mainstay of treatment now is tacrolimus and cyclosporine. These are mainstay. And second line drugs are MMFs, azathioprine, steroids are the essential adjuncts. So mTOR inhibitors like sirolimus and everolimus have established role in patients who have renal dysfunction. So this is an MCQ. When patients with the calcineurin inhibitors developing nephrotoxicity, what drug will you use? I will use sirolimus and everolimus. And in those patients who had HCC, we can use sirolimus and everolimus. They are much better because calcineurin inhibitors and other drugs like mycophenolate mofetil all will stimulate the tumors. Therefore, that is points from this table. Please go through this table. Interesting table. Calcineurin inhibitors are causing nephrotoxicity. Mycophenolate mofetil is causing increased risk of cancer. Therefore, in case of cancer or in case of nephrotoxicity, go for mTOR inhibitors. mTOR inhibitors like sirolimus and everolimus are used in nephrotoxic patients and patients who are already having HCC. One problem with mTOR inhibitors is it is causing hepatic artery thrombosis can be caused. Please remember, it can cause hepatic artery thrombosis. Please go through this table. You can get few questions from this table. Most common indication of retransplant of liver. Can you tell me what is the most common indication of retransplant? Yes. Answer this question. Retransplantation of liver. You have done a transplant and immediately you are going for retransplant. Answer is primary non-function. What is this primary non-function? This is one of the most scary complication by the transplant surgeons. After doing the transplant, the liver is not functioning and there is increasing ALT, increasing AST to enormous levels. ALT, AST is increasing very highly and the liver is not functioning, but there is non-immunogenic. It is non-immunogenic and there is no hepatic artery thrombosis. Everything is normal, but liver is not functioning. It is because of ischemia reperfusion injury. Please remember, why does this happen? It is because of ischemia reperfusion injury only. This primary non-function of liver happened. So please don't forget, the answer is A. It is defined as an aggravated form of reperfusion injury. Incidence is 4 to 8%, and it is the most common indication of retransplant. It is almost always a problem associated with DDLT, but can present in live donor also. It is most commonly seen in cadaveric liver because we infuse University of Wisconsin solution for them. Okay, this is primary non-function. What are other complications? Please remember the other complications of transplant. Hemorrhage. Hemorrhage, 12.5% needing re-explorations. Don't forget this point. 12.5% will need re-exploration. And who will be the most common case? Ex situ split transplant. Ex situ liver transplant have high blood loss from the cut surface area. This type of hemorrhage is less common in situ liver transplant, in situ splitting of liver. I told you already the reason. Number 2, and in live donor transplant, it is less common because in live donor also, from the cut surface, we meticulously arrest the hemostasis. So excessive hemorrhage is also common if the graft has sustained a severe reperfusion injury. That is also a reason. But very commonly, MCQ point, who will get hemorrhage more commonly? Mean ex situ split liver transplant will get hemorrhage more commonly. Don't forget this MCQ. Regarding the vascular complications after transplant, false statement is, regarding the vascular complications after transplant, false statement is, most dreaded complication is hepatic artery thrombosis. Yes, another nightmare of liver transplant surgeons is hepatic artery thrombosis. Early cases of hepatic artery thrombosis presents with raising aminase levels. Endovascular interventions are helpful? No. Late hepatic artery thrombosis presents with bile duct strictures and abscess. Now tell me, what is the cause of hepatic artery thrombosis? Hepatic artery thrombosis is a dreaded complication, may occur spontaneously or as a part of acute rejection. Don't forget this. It is more commonly when you are seen operating a primary sclerosing, second MCQ. Hepatic artery thrombosis happens following acute rejection. It is more common after PSC. Incidence is 1 to 10%. Anatomical variant grafts such as, who will develop this more commonly? This is less common in whole organ liver transplant. Whole liver transplant, the artery will be very big and we have done a simple anastomosis. Whereas in a split liver transplants and in live donor transplant, the artery will be small. Therefore, reduced split liver, reduced liver, live donor have high risk of hepatic artery thrombosis. So whole organ has less risk of hepatic artery thrombosis. Split organs have more risk of hepatic artery thrombosis. And this happens within 4 weeks. Within 4 weeks, it is usually seen in hypercoagulable state, elderly donors, and technical factors. So So many causes are there. Whatever it is, immediately do Doppler ultrasound and CT angiography to confirm the diagnosis. There is no use of endovascular interventions and thrombolysis. In UK, this is coming under super urgent liver. I need a super urgent liver. Immediate transplant you can save, otherwise they will die. Super urgent liver scheme is used in these patients. So up to 21 days after transplant, if a patient develops hepatic artery thrombosis, we do a super urgent liver scheme is available in that in UK. Okay, immediately we have to do the transplant. Late is one which happens after 4 weeks. It is asymptomatic, so no need to worry. It is because of bile duct strictures and liver abscess. This is because of ischemic insult. This is because of the ischemic insult. All of you know very well, bile duct is supplied only by hepatic artery, no portal venous supply. So therefore, bile ducts, when they had a poor blood supply, like in DCD donors who had a warm ischemia, those patients will develop hepatic artery thrombosis late, and because of the thrombosis, the bile ducts will develop stricture, abscess, etc. Sometimes you can do dilatation, sometimes you need transplantation for these patients. Portal vein thrombosis and stenosis are rare and can present with features of portal hypertension. Management usually is endovascular. Portal vein thrombosis, no need to worry. Usually you can easily manage with the endovascular intervention or even by a bypass or sometimes pre-transplant. Similarly, hepatic venous obstruction can also be treated by a stent. See, hepatic vein obstruction, portal vein obstruction, late hepatic artery thrombosis. These three cases are not dangerous, whereas dangerous is early hepatic artery thrombosis. These three can be managed by endovascular, surgical, or even transplant again. But hepatic artery thrombosis, only option is re-transplant immediately. Achilles heel of liver transplant, I already told you it is bile duct anastomosis. Now, biliary complications are very, very important. Biliary complications include bile leak, stricture, biliary anastomotic stricture, non-anastomotic stricture, bile duct sludge and stone, and vanishing bile duct syndrome called as ductopenia due to chronic rejection. All these are because bile duct is only supplied by one artery, biliary artery. And the biliary epithelium being more liable to ischemic injury, suboptimal preservation of peribiliary plexus results in ischemia reperfusion injury. The incidence of biliary complications is higher in live donor transplant and other anatomical variant grafts than in old graft liver transplant. This is because of small size of the ducts, multiple duct anastomosis, and also cut surface leak. It is high in live donor liver transplant. Split liver transplant is more common than whole liver. It is again because of the smaller ducts. We are going to do the anastomosis. We are having more risk of biliary complication. Biliary anastomotic stricture is easily treated by, we can treat it by anastomotic restenosis by endoscopic dilatation or by stent insertion or by a true and Y hepaticojejunostomy. Anything can be done for anastomotic stricture. For a non-anastomotic stricture, it's the most severe form. Anastomotic stricture is the easiest to treat. So like this, it will be there. Okay, this will be like this. For a non-anastomotic stricture, we don't know the stricture where it is. It is the entire bile duct is having a ischemic type of biliary lesion. It is more common in whom I told you. I told you this is most severe form of biliary stricture and it is common in donation after cardiac death. Okay, it is more common 25 to 30% with DCD grafts, but it is less common with this is brain dead grafts. So this includes rule out hepatic artery thrombosis. I already told you biliary stricture can be due to emoji on screen. Oh, I don't know which emoji is coming. This is shown, huh? No, it is coming. It's coming now. Is it fine? Okay. So management of biliary non-anastomotic stricture is and rule out hepatic artery stenosis or thrombosis. So eventually, most of these non-anastomotic stricture patients will need transplant in future. So this is a very nice table, simple table explaining you the entire complications of liver transplant. Whatever I am discussing in complications of liver transplant, you know, it is a big chapter in Bloomgard. Those who have read liver transplant Bloomgard, you can understand every paragraph I am discussing here in this chapter is one full chapter in liver. Full chapter of liver transplant in Bloomgard. Extraordinary chapter in but it is not possible to read for Neet SS exams. So just remember what I'm discussing in this chapter. So early complication within 6 months, late complication after 6 months. Primary graft function, this non-function, delayed graft non-function, bleeding, hepatic artery thrombus, portal vein thrombus, hepatic venous outflow obstruction, bile leak, bile anastomotic stricture infections. Non-anastomotic stricture, ischemic cholangiopathy, more common in donation after cardiac death. Vascular stenosis, these are all not thrombosis, they are stenosis. Here there are thrombosis, here there are stenosis. Late hepatic artery thrombosis, biliary anastomotic stricture, hernia, all these are common general problems, renal impairment, disease recurrence, cardiovascular disease, etc. So liver graft dysfunction can happen any time after transplant. If not identified, early graft loss can happen. So if a liver graft dysfunction is not identified, early graft loss can happen. The most presentation in is asymptomatic elevated liver enzyme levels. What is the most common cause for this scenario? Most presentation is asymptomatic liver enzymes. What is the most common cause? Yes, what is the common cause of this? Early graft loss is commonly due to acute cellular rejection. So we are discussing non-graft function now, primary non-function. So this is acute cellular rejection. It's acute rejection. Acute rejection manifests as acute cellular rejection is the most common cause of graft dysfunction and is usually treated by increasing the dose of immunosuppressants. So you have to increase the dose of immunosuppressants, which includes pulse steroid therapy for 3 days or more, depending upon the degree of rejection. Even if rejection is suspected, it is important to rule out biliary complications, vascular complications by doing a Doppler scan, and liver biopsy is usually performed through percutaneous or coagulopathic patient. You should go for a transjugular route. So acute rejection should be noted. So acute cellular rejection is a common presentation of asymptomatic elevated liver enzymes. Common cause of this is acute cellular rejection, which can happen up to 6 months. This can happen. Okay. Follow-up, therefore, should be very serious. So first 3 months, you have to be very closely following them. For the first 3 months, 1.5 months, you should ask them to come every week once. Next 1.5 months, ask them to come every fortnight, means 14 days once. So 3 months, you have to be keeping them a close watch up, because many times it's an asymptomatic elevation. Unless you raise the immunotherapy, they will lose the organ. So therefore, 1.5 months weekly, next 1.5 months, 14 days, and afterwards you can increase the duration of follow-up. Late graft dysfunction is usually due to chronic rejection or hepatic artery stenosis or venous outflow obstruction or biliary obstruction or recurrence of primary disease like hepatitis C or NASH or any other viral infection. All these can cause late graft dysfunction. The following are the risk factors for the recurrence of tumor. Very important and interesting question. Highly expected Neet SS question. Can you guess the answer? The following are the risk factors for recurrence of transplant, except. Yes, who will have recurrence among this list? A HCC patient coming for recurrence. What is the answer for this? DCD donors. Yes, DCD donors. Non-viral etiology is wrong. It is viral etiology. High AFP level. High AFP level is correct. Beyond Milan criteria. This is from a table from Bailey and Lowe. So this is recurrence after liver transplant increased over the past decade, and as many more patients living more than 50 to 20 years with their liver graft. So cancer recurrence and disease recurrence has been more because the liver transplant survival is more than 20 years. Like what all disease getting recurrence? Malignancy, virus, autoimmune, NASH, alkali, all these are getting recurrence. So this recurrence is most important is malignancy. And who will have risk factors of tumor recurrence? Large tumor burden beyond Milan criteria, poor tumor biology, microvascular invasion, high AFP, viral etiology, obesity, percutaneous biopsy has been done, longer waiting time, higher donor age, DCD, higher burden of immunosuppressions. So these are the risk factors of tumor recurrence. So therefore, what is included? It is viral etiology is included. So not non-viral etiology. Non-viral etiology is not a very important risk factor. Viral etiology. B virus induced HCC, C virus induced HCC. So what about virus recurrence? HPV recurrence has been reported in 10%. And new drugs are now available like hepatitis B immunoglobulin and lamivudine has reduced the recurrence rates. Similarly, HCV recurrences also has been reduced with the help of many new drugs which are introduced like protease inhibitors. So HCV, hepatitis B virus, both risk factors are decreased nowadays. Virus recurrence is decreased. Remember that point. Okay. Autoimmune disease recurrence. Primary biliary sclerosis, primary sclerosing cholangitis recurs in 20% of the patients. So 20% of them will have a recurrence, and some of which may be a de novo secondary disease also. Some of them may be a new disease which has happened. So that is also seen autoimmune disease. So what are this is the MCQ for your exam. What are the diseases that recur after liver transplant? B and C, PBC, primary sclerosing cholangitis, autoimmune hepatitis, alcoholic liver disease, NASH, Buchiari tumors. All this will recur after liver transplant. So prognosis after liver transplant is extraordinary compared to other organs. 94% survive in 1 year, 84% survive in 5 years, and 72% survive in 10 years. So the common cause of death after 3 years of liver transplant in recipient nowadays is not due to rejection or anything else. It is because of cancer or CVS cause. So these two are the causes of death after 3 years. Now the cause of death in liver transplant patients, mostly non-transplant related like cancer and CVS causes, is a common cause of death, and are less due to chronic rejection or recurrence of primary liver disease is very less. So this is what I am discussing. Cold preservative solution. Usually what is discussed in general surgical concept is, once you retrieve the organ from a cadaver, immediately you should perfuse the cold preservative solution known as University of Wisconsin solution. And you transfer this organ from one place to another place in a static cold storage solution. Now new concepts have come in which instead of, because when I'm going to keep this as such, the metabolics, toxic metabolites are going to get stored inside, and when I reperfuse, they will enter the circulation and cause primary dysfunction or reperfusion syndrome. To prevent that, now many concepts have come. Hypothermic machine perfusion. Hypothermic, the cold solution will be continuously going, continuously coming out, continuously going. So this is hypothermic machine perfusion. Normothermic. Instead of a cold solution, let me infuse a warm blood. Warm blood is fused. So blood is infused. Machine perfusion. This is cold solution perfusion. Instead of taking the organ and perfusing, let me perfuse the organ in situ in the abdominal itself. The organ is not taken out from the cadaver, from the brain dead, and the organ is continuously perfused through all the abdominal organs are perfused. That is called as normothermic regional perfusion. So 3 types of perfusion are explained in Bayesian law. So hypothermic, normothermic, regional perfusion. Mars is not a part of cold storage. Okay, it is different. We'll discuss about it. So please don't forget cold ischemia method to prevent reperfusion injury, cold solution, hypothermic machine perfusion, warm blood, normothermic, and another technology is in situ normothermic regional perfusion. So don't get confused. I'm taking the organ, infusing with a cold solution, taking out the cold solution like a cycle. Infusing the blood and taking it out like a blood is normothermic. Another one is infusing the solution, infusing the blood in the abdominal organ itself is called as in situ normothermic regular regional perfusion. And there is another update from, this is actually a short notes for final MS students writing the recent advances. What are the liver support devices? Liver support device is same like dialysis machine for a kidney support. Same way, acute liver failure patient has a mortality of 50 to 80%. Until we take them for liver transplant, we need to do something, no? That bridging of the liver transplant, we have separate devices which functions like a dialysis machine, which removes toxic substances, bilirubin, bile acids, aromatic acids, medium chain fatty acids, everything is removed. And some examples of commonly available artificial support system are MARS, molecular absorbent recirculating system, HEPA wash, liver wash, HEPA wash, MARS, biological liver is also available, taken from animal or human liver is also available. That liver support detoxification is achieved by portal and artery perfusion. Some commonly available biological livers are extracorporeal liver assist device and hepat assist. So ECE, extracorporeal liver assist device and hepat assist device are the various devices used in this. So this is about the very important basic concept. Let us discuss a few MCQs from Sabistan. Most common indication of liver transplant after 2010 is Yes, answer is alcoholic cirrhosis. Before it is B virus and C virus. Now it is alcoholic cirrhosis. This is a list of common indications of liver transplant. Okay. American Gastroenterologist Association for acute alcoholic hepatitis recommends for liver transplant at MELD score above. So MELD score above 15 is put in waiting list, but above 26 only will be transplanted in acute alcoholic liver disease. Okay, above 26. So when should a patient stop drinking alcohol? Now, no time limit. New update, no time limit. Even a patient who had alcohol last week also can be taken for surgery. Previously, 6 months of abstinence is compulsory, but it is no more. That is why now we are doing transplant. After doing the transplant, those guys go and drink and come again with the liver failure. With the new liver, they come to us with the liver failure in 2-3 years. Actually, it should be 6 months of abstinence should be there, but now there is no time limit from new substance. A patient is planned for liver transplant due to liver failure. He is having osteoporosis severely, alkaline phosphatase elevated, anti-mitochondrial antibody elevated. So this is a clue. AMA increased. What is the diagnosis? AMA is increased in primary biliary cirrhosis. Okay, primary biliary cirrhosis will have AMA increased. So primary biliary cirrhosis or cholangitis, osteoporosis is seen, fatigue, pruritus, and there will be jaundice, xanthomata, and AMA is positive. Another disease like PSP, primary biliary cirrhosis, is autoimmune hepatitis. There will be anti-nuclear and anti-smooth muscle antibodies are elevated. They both have same presentation. Both of them are children coming to you with the elevated alkaline phosphatase and other enzymes. But in case of autoimmune hepatitis, alkaline phosphatase is less elevated. AST, ALT is more elevated. AST, ALT is more elevated. Alkaline phosphatase is less elevated. As you know very well, the reason is because alkaline phosphatase is elevated in obstructive pathologies. So PBC is an obstructive pathology. Therefore, there is more elevated. In autoimmune hepatitis, it is less elevated. Antibodies are most important. Anti-mitochondrial, anti-nuclear, anti-smooth muscle. These antibodies will decide the course, but biopsy is essential for autoimmune hepatitis. Following points are included in King's College criteria in liver transplant for acetaminophen-induced liver failure except. So don't forget paracetamol criteria. In paracetamol criteria, pH less than 7.3, we will immediately do transplant. Or three important things. They are prothrombin time elevated, grade 3-4 encephalopathy, or serum creatinine more than 300 micromoles. So this is what used in paracetamol. So paracetamol pH less than 7.3 or prothrombin time increased, grade 3-4 encephalopathy, serum creatinine. See, this you should understand. Paracetamol can damage the liver as well as kidney. Okay, therefore, liver, kidney, and coming to the brain. So 3 organs are damaged. So therefore, it includes everything except bilirubin is not included in paracetamol. Bilirubin is included in non-paracetamol induced liver failure. So this is a picture showing you King's College criteria. INR 6.5, creatinine more than 3.4, and grade 3 encephalopathy, pH 7.3. Now recently they added 2 more factors in King's College criteria from Bailey and Love. Addition of lactate and phosphate thresholds to criteria increases sensitivity of the value. So increases the sensitivity of King's College score. And non-paracetamol criteria, prothrombin time more than 100 seconds, or any 3 of this include age, non-A, non-B, jaundice for 7 days, prothrombin time increased 50 seconds. Here it is bilirubin. Okay, here it is bilirubin. Here it is creatinine. Usually they will change this. In a non-paracetamol, what is not included? Creatinine not included. In paracetamol, what is not included? Bilirubin is not included. So the answer here is bilirubin. So this is a repeat question. Same question has been asked many times. The following are contraindications for liver transplant except severe cardiopulmonary decompensation, portopulmonary hypertension, yes, uncorrectable to less than 50, hepatopulmonary syndrome, not correctable on 100% oxygen, HIV patients, active alcohol consumption. D and E are no more contraindication. As I told you, D and E are no more contraindication from Sabiston. So what are the contraindications? Means intraoperative hypoxia due to portopulmonary hypertension, which is uncorrectable to less than 50, or PaO2 not correctable with 100% oxygen, we cannot do. Infections We can do transplant, especially when it is a PSC with liver abscess. We can do uncontrolled sepsis is a relative contraindication. And other contraindications, extrahepatic cancer is a contraindication. HIV can now undergo successful transplant. Active alcohol is not a contraindication now. What is added in MELD score now to increase the positive predictive value? It is newly added is to creatinine, bilirubin, INR. They have added sodium. Serum sodium is included in MELD score from this concept. So there is a, when will you put them on waiting list? When the score is more than 15 only, we will put on waiting list for transplant. Please add sodium. So common in this question is 100 times asked MCQ. You should never have doubt in this question. Common indications of exception: HCC, HPS, portal pulmonary, hepatopulmonary syndrome, portopulmonary hypertension. We have to do transplant earlier. Don't wait, because they will become irreversibly damaged liver. So amyloidosis, hyperoxaluria, cystic fibrosis, cancer, and I told you UK super liver transplant scheme done for hepatic artery thrombosis, which occurred within 14 days. Here it is mentioned as 14 days. Bailey says 21 days. So UK it is 21 days. US it is 14 days. Okay. So in these cases, these are all exceptions to liver transplant based on MELD criteria. We don't wait for MELD criteria. Donation after circulatory determination of death may have excellent outcomes in the experienced hands. But the major drawback in these cases is what? Donation after circulatory determination of death, patients have excellent outcomes. But the major drawback in these cases is ischemic coagulopathy. Yes, cholangiopathy. That's correct. Because of loss of blood flow, they have damaged bile duct. Mr. Ramu, 59 years, male, underwent liver transplant from a deceased cardiac death patient on post-operative period. AST, ALT are raised above 5,000. Serum lactate is very high. What will you do now? DCD donor, patient has gone for a AST, ALT raised. Serum lactate is very high. Therefore, we have to go for a redo transplant. That's all. This is a case of primary non-function is a serious complication requiring retransplant. The most common causes are unrecognized procurement error, fatty fibrotic DCDD, arterial complications. Arterial complication, typically the patient will not wake up, lactate will remain high, AST, ALT will keep on raising. This is primary non-function nightmare of transplant surgeons. Arterial complication, another nightmare already discussed. Yearly arterial thrombosis, even if not associated with primary non-function, should undergo retransplantation risking. This is also associated with increasing AST, ALT, high bilirubin. Post-operatively increasing AST, ALT, increasing lactate is a serious issue in liver transplant cases. GRWR, false statement is GRWR less than 0.5 has small for size syndrome. Ideal is 0.8 to 1. High GRWR is needed in case of donor liver, fatty liver, donor age more than 50. We need a high GRWR. Low MELD score recipients will need high GRWR. No, it is high MELD score. Those who are having 40, 44 and all, they will need high GR, bigger liver. So answer is D. So small for size syndrome, GRWR 0.5 or less will go for various issues, like they will go for failure like jaundice, coagulopathy, ascites, encephalopathy, renal impairment, death. Retransplant with a larger allograft may be necessary for these cases. High GRWR, even more than 1.2, can be done for patients who are older donors, 50 years, fatty liver donors, high recipient MELD. So high recipient MELD. So recipient is having a high MELD score. In such cases, it should be more than 1. Okay. This is a picture showing you. The picture showing you normothermic machine perfusion. Using what? Using a blood, warm blood, which is perfused and into the liver. This is the liver here. It is perfused into the liver and taken out. This is a normothermic perfusion. Examination of perfusate. When I examine the perfusate, examining the perfused blood, I can differentiate whether it is a good liver or bad liver. Drugs administered to enhance the graft, rehabilitate grafts with oxygenation, extends the viability of the graft, not useful for safer transportation is wrong. So by doing this machine perfusion, we can safely transport to a distant place. Therefore, this is very important. This Sabiston gives only about normothermic machine perfusion. Machine perfusion have some advantages of assessing the quality of the graft. It can be either used either to rehabilitate grafts from ongoing oxygenation, and you can give some drugs needed, and it can be help in safer transportation. All these purposes, it is very helpful. So this completes the liver transplant. We'll do the pancreas and small bowel transplant soon. Okay, we'll be doing that also soon. So we had around 300 plus students, but only 35 students are attending. I think they are all planning for a recorded session. Please go through this video again and again. This is a little tough chapter because I told you, as usual, it is more theoretically we are reading. We are not going to for a more practical experience is very less for us. So you keep on again and again reading this concept to make it strong in your brain. If you don't keep revising again and again, you will forget what is. After a few months, you will have a doubt whether it is GR, WR, etc., etc. It will be done 2-3 days. Within 2-3 days, I will do that. Small bowel and pancreas together, we will do. Okay. So thank you all. Thank you, friends. We'll see you on another session. Thank you.